And on that note, one of the things I just wanted to ask Mike and Erica is just, are there any cautions or limitations when, later on we're going to be showing the map and the interactive map, and patients can go in and look at it. And I just wanted to get a sense from you, are there any cautions, limitations, any kind of warning signals that you should tell people who are looking at this data in the context of how the study is designed and so on?
Yeah, that's a great point, Gail. And there are a couple of things that I'd like to emphasize. So first, we have asked healthcare providers to only report cases of confirmed coronavirus. And that means that their patient had to have actually taken a test and tested positive, not just had the symptoms that were consistent or suggestive of coronavirus. And that means that any findings that we get, we can be more confident that it is truly related to coronavirus and not something acting like coronavirus, like the flu or allergies or something else. But the downside of that is that there are many, many patients who may have had coronavirus who never got a test and therefore haven't been included in our registry. And there is the possibility that that then selects in our registry for the patients who may be sicker, because it's more likely that the patients who get tested would have been the patients who presented with more severe symptoms and had to go to the hospital and therefore got the test. So our death rates and our rates of hospitalization and rates of people requiring a ventilator may be higher, and actually I'm pretty sure would be higher than if we really had if we were really able to study everyone with coronavirus, and including those individuals who did not get tested.
Yeah, I think it's a great point. And just for everyone to know that, so sometimes when you look at a database like that, given the limitations that Erica has described, you might see that the numbers are overinflated. Particularly, they might look scarier than they probably really are if you were able to study this, broadly across the whole world. But having said that, what's key with these types of databases are having people who have bad outcomes and people who have good outcomes, and having that spread allows you to start to explore whether there are certain factors that might lend somebody to have a bad outcome versus a good outcome. For example, being on a drug like prednisone versus being on a drug like Remicade. So it still allows us to do that type of research, but just to recognize that when you look at the database, the numbers are probably overinflated relative to what's really happening out in the population.